in Pakistan. It comes in two forms: monthly oral form. This was the first medication that came as monthly oral form of 150 milligram, and quarterly 3 milligrams IV. And most of the studies were actually done on 2.5 milligram oral dosing, but the two most commonly used drug dosing is monthly and quarterly IV drug. Daily ibandronate has been shown to reduce vertebral risk fractures by about 62%. And as per this slide, it shows a consistent decrease in risk fracture over the period of 3 years. We'll skip this slide. Ibandronate, now what has been IV ibandronate, which is IV Bonviva? It is approved by FDA for the treatment of osteoporosis. But the oral Bonviva is approved for treatment and prevention. So if somebody has osteopenia, you can give them oral Bonviva. Zoledronic acid, which is approved by FDA about 2 to 3 years ago, showed very good results. In 3-year trials, it showed the risk of vertebral fracture reduction by about 70% compared to placebo, and risk of hip fracture reduction by about 41%, and a consistently increase in BMD at both spine and hip. Now, interestingly, it's been approved for both prevention and treatment of osteoporosis, and last year it was approved by FDA as a single injection every 2 years, which is, I think, very remarkable that for osteopenic patients, we can just give one injection every 2 years, and the patients don't need to take anything else. Teriparatide, which everybody, I think, knows, it's a parathyroid hormone analog. It's given as a subcutaneous injections. Now, this is the anabolic form of it, forms newborn. And therapy is maximum given for 18 months. And after 18 months of treatment, the patient should be switched to bisphosphonates. By NICE guidelines, these are European guidelines, patients, Forteo, I think they're called Forteo in Pakistan? Forteo. So when the people ask you when should we give Forteo, that by the NICE guidelines, Forteo should be given to patients who have got multiple fragility fractures, patients whose BMD is really very low, and who have not responded to bisphosphonates, and patients who have got long-term history of corticosteroids. This is generally the indication for giving Forteo because of the cumbersome thing that you have to do it every day, a daily injection, and plus the cost. It's very expensive. It's expensive, but it is effective. It has shown to reduce the vertebral fracture risk by about 65%. And it has shown to consistently increase the BMD at spine 9.7% and 13.7%, and at hip by about 5.1%. Strontium. This is something which is drug licensed in Europe and available in Pakistan now, but it is not FDA approved. I just got to know about it recently. It has a dual mode of action. It works on osteoblast and osteoclast, so it reduces the bone resorption and enhances the bone formation. And a study in NEGAM, I think it was in 2005, showed that it reduces the vertebral risk fracture by 49%. And it comes in some sachets in Pakistan, and you drink it twice a day, mix it with water. Once a day? Okay, once a day. And as per recommendation, people who have failed bisphosphonates, who cannot take bisphosphonates as first line of therapy, only those people should be tried on those, because the first line of therapy, I think, still stays to be the bisphosphonates or the other treatments. This is the overall summary. We'll skip on it because of the time restraint right now. The pros and cons of different things. Calcium and vitamin D, it's cheap and accessible, but partial efficacy. HRTs are effective, but of course there is increased risk of breast cancer, DVT, MI, and CVA. SERM, raloxifene, decreased vertebral fracture, decreased breast cancer, but no hip fracture data, and it has less effect on BMD. Bisphosphonates, very good, but the problem is with GI intolerance, except for the IV bisphosphonates. Teriparatide is very effective, but it's expensive in daily injections. Don't look at these slides. I have some, we have given some papers out. So everybody can take some flyers. We have made copies of these presentations, and you can take it. And these are some of the sites that you can look about osteoporosis. I just want to quickly touch, because I think we're running out of time, on the future treatment option of osteoporosis. The new and emerging treatment, the Nirsumab, is actually not an emerging treatment. It's already FDA approved. It is It's a fully human monoclonal antibody, which, if you remember the previous movie, it binds to rank ligand. Rank ligand is the bad mediator which activates the osteoclast. And this is given as a subcutaneous injection every 3 to 6 months. And it is FDA approved, available in the market, but not yet here. And there are some inhibitors which are coming out. These are oral drugs, most of them. Cathepsin K is an enzyme which works on, which is released by the osteoclast, and it chews the bone. Okay, so there's some anti-cathepsin A, which is called bellistatib, I suppose. It already has a name. It's in phase 3 trials, so hopefully in about a year or two it should be making the market. Then there is OGX58. It is an inhibitor of sclerostin. Sclerostin is a protein which is released by osteocytes, and it inhibits the new bone formation. So this is an anti-sclerostin. It's again another oral drug which is coming out. And this is, we won't go over there. Okay, now what is the take-home message from my talk is please do not wait for any fracture to happen. Go ahead and treat osteoporosis and treat it now.